Good afternoon. This is the House Appropriations Subcommittee on Health. While we are waiting for a few more members to get here, anyone that would like to speak, please come forward and sign up on the sign-up sheet on the table. Thank you. For those that have just joined us, There is a sign-up sheet up front. If you want to sign it, please do. Thank you. Again, welcome to the Health Appropriations Subcommittee meeting, and happy to have you here today. And Chairman Hawkins is going to open us with a word of prayer.
Please bow your heads. God, Father, we come to you today, this afternoon, asking for your wisdom and blessing in the decisions we're about to make, and help us choose the right path for all Georgians. In your name we pray. Amen.
Thank you. All right, we're going to get started, and our call, the first one will be the Georgia Board of Health Care Workforce. If you'd come forward.
Good afternoon. Thank you for allowing me to present to you all today. Because I'll pull up this presentation. All right, so just to refresh, I'm from the Georgia Board of Healthcare Workforce. My name is Chet Basine. I have the pleasure of serving this wonderful board. High level, we are the state agency that deals with medical education, dental, nursing, loan repayment, medical school grants, and a lot of data processing in terms of workforce distribution, supply, and all that. So at high level, that's what we do. But in the spirit of time, I'll cut the details out. What you'll see in front of you is, in the next several slides, is our 6 programs. On the left-hand side of each slide, you will see the tracking number, if that's your preference. This is the administration budget. What you will see in 17.11.1, that's the generous salary increase that the governor has put in for the budget. That I can attest that the staff is pleased to see, but told them it isn't final. But that's that. 17.11.2 is just for DOAS services for our agency premiums. That's $2,997. 17.11.3 is Georgia Building Authority, just for the rental rates and for Capitol Police Security and operational expense. We did move from 2 Peachtree to 2 MLK just almost a year ago, and it's been a very pleasant transition for our group. And then last but not least on this page is 17.11.4, that it's just funds for the Merit System Assessment Billings. And then this second page is just a continuation of the administration budget. There was a mention of at 17.11.5 using existing funds for statewide evaluation gaps. There's no amount there. And then at 17.11.6, reduction of funds to align with budget expenditures, a reduction of $11,262. The net increase for our budget here is $32,282, and then that's the grand total, $1,811,283. That is the administration budget. That's us in the back office, again, doing the work of the great work that you all let us do. The next one is our graduate medical education. This is where the residency slots and the medical education primarily come out of. You'll see an increase at line item 17.12.1, 79 new slots for graduate medical education. That's at a variety of programs around the state and a variety of specialties, but that's $1,494,596. And then at line 17.12.2, you'll see a reduction of $62,870. That is just due to a reduction in the FMAP amount. So it's just to offset the increase coming from the Fed, so decreasing the offset from the state's contributions. You'll see a program net of $1,431,726. That is, again, the graduate medical education program. Let's pause to see if there's any questions there. If not, I'll move on to the Mercer School of Medicine operating grant. And line item 17.13.1, you will see an $850,055 amount. That is funds for their Columbus, Georgia, their new campus. It's part of a 7-year expansion plan. This is in the 5-year. This is the 5th year of that. That is the only item in this program, which is the grand total again is the $850,055. Morehouse School of Medicine, there were no changes suggested by the governor. Physicians for Rural Areas, this is the program, it's called Physicians for Rural Areas, but this is where all the loan repayment for physicians, dentists, nurse practitioners, and physician assistants come from. So that is that program. Again, no changes over there. Undergraduate medical education, again, no changes over there. And the last page is just each program that I've gone over, the 6 programs, the original FY24, the governor's recommendations, and then on the final right-hand column, the recommended FY25 budget per the governor. Any questions?
Yes, as I do have a question. Do you have a breakdown for the residency slots?
For the 79 that I mentioned earlier?
Yes.
We do maintain a file that has the different hospital sites and specialties that put in for where their increases are coming from. I don't have them memorized, but I'd be glad to contact.
Could you send that to us? The committee would need to see that.
Absolutely.
Thank you. Chairman Hawkins, you have a question?
Chet, on this physician for rural areas, which includes dentists, you and I talked about 3 more slots for the dentist, this spring, early summer. Is that in here, or do we need to ask that from the committee?
That, what you're referring to is not in there. What is in here is just the existing slots that have carried
Existing
over.
slots. Okay, no additional. Okay, thank you.
Are there any other questions? I see none. Thank you for your presentation. We appreciate it.
Thank you.
Okay, our next presenter will be Dr. Dennis Ashley of the Georgia Trauma Commission, if you'd come forward.
Thank you, Madam Chair. We have some good news today I want to share with you that's tied directly to the budget, so I'll move through that pretty quickly. I know it's been a long day for you, so I will speak fast. Please don't think I'm being rude. I'm just trying to be respectful of your time. Please interrupt me if you have a question. You won't throw me off at all. I'll be happy to answer those. So since the commission was created by Senate Bill 60 in 2007, now in Code 3111-102, we have really worked hard on the trauma system, and I think it's a time for a victory lap, not only for the commission and the thousands of stakeholders and healthcare providers across the state, but also our legislature, because without that clinical piece and the legislative body, we cannot do what we do. And I think you will see, working together, what we've been able to accomplish over the last several years. Liz, I'm having a little difficulty here. I'm using the various arrows, up, down.
Okay.
Maybe it's just a screen. Okay. So just to give you an idea of where we were in 2007, I get this question a lot from the legislators when they want to see a map and see where we were. You can see the dots are trauma centers, and those gray areas are within an hour driving distance around a particular center. You can see there's a lot of non-colored areas in the state when we started in 2007. So we worked hard over the years to increase access, increase the number of trauma centers. And we've actually gone from about 15 to 16 trauma centers up to about 34 now. So we've more than doubled the number of trauma centers. And you can see more dots equal more lives saved and more access. So the state is looking better now with more colors representing better coverage. What that means when I said about access, you can see when the commission was formed around 2007, only about 70% of critically injured patients were actually going to a designated trauma center. That means that they were not getting the care that they needed or not getting the access to high-level or specialty trauma care. And through the years, you can see that line has gradually gone up to where now we're up well over 90% of critically injured patients getting access to the care that they need. So with increased number of centers, increased access, and better education, it's not surprising that our mortality has improved. This is CDC data. You can see the teal-colored line is really, we're looking at deaths per 100,000, which is the way the CDC looks at it. You can see in 2003, the national average is in teal. You can see Georgia and the Southeast region are sort of tied. They're both well above the national average or worse than the national average for mortality. That comes out to be about 16% worse than the national average. And you can see now in 2019, we've bent that curve below the national average. Georgia is 6% better than the national average in mortality. And you can see the Southeast region, which are, the states around us, is still well above the national average. So this, you can see through increasing access, getting people to the right place at the right time, and increasing the number of trauma centers, this is a huge win for the state and something that we can all be proud of. Now, trauma center readiness, I need to spend just a minute on that because that's tied a lot to our budget, and you'll see why that's tied to our budget in just a moment. When I say readiness, I'm not talking about indigent patients or insured patients. We're talking about the cost of readiness to be a trauma center that's mandated by the American College of Surgeons in that gray book there on the right-hand side of the screen. Every item in that book, whether it's a piece of equipment or whether it's a team or whether it's a surgeon, everything has a cost. And so over the last several years, Georgia has led the way. The commission has published several papers on this, and other states are now looking to us on the cost of readiness because we have really incredible data on this as one of our areas of focus. And you can see that we've identified the cost, and this has been published in peer-reviewed journals. For a level 1 center, it's about $10 million. For a level 2 center, it's about $4.9 million. And most of this is made up with the extraordinary costs of the medical staff that you have to have 24/7. Once we were successful in identifying the cost for level 1 and 2 centers, and again, there's only about 1 or 2 papers in the literature about this before we started publishing. There was no papers about level 3s and level 4s, which are centers that don't have to have quite as many resources and are really on the front lines, many in rural Georgia. You can see we have identified the cost there at $1.7 million for a level 3 and about $81,000 for a level 4. So for the first time when we put all this together, you can see, I won't go over all these numbers, this is really for your reference, but you can see in 2007 and 2008 when the commission was formed, and at that time Governor Perdue put in a one-time funding source in the amended budget of about $58 million. And if you read across the slide, you can read to the far right, that was about 58 cents on the dollar. And that's an interesting number. We really didn't know what that meant at the time, but as we've tracked the data over the years, we'll come back to that number at 58 cents on the dollar. That seemed to be a good sweet spot, if you will, to keep people into the system. And what I mean people, I mean the trauma centers in the game, and allowed us to recruit other centers. As I showed you, we've been able to double the number of trauma centers. If you look down at the bottom of the slide now, down to 2022, you can, if you read across that, you can see now with the increased number of trauma centers and the increased readiness costs, as you add more centers, costs go up. we're down to about 8 cents on the dollar. So this is really sort of at the bottom or in the basement, if you will, as far as our readiness costs. We can only fund 8 cents on the dollar. Now, if you look at level 3s and level 4s, we didn't have data on them until 2019, until we were able to track this. And you can see down there in 2023, our budget is about $22.9 million. And if you read across the page, you can see that that puts them at about, I think that's 6 cents on the dollar. Again, for level 3s and 4s or 1 and 2s, we're in the single digits on readiness costs. So now if you like to look at, graphs, you can see here in teal colored, that is the actual readiness cost for the level 1 and 2 centers, and you can see that's gone up over time. And you can see our funding's been held constant down around the $8 or $9 million mark, and you can see the huge gap in 2023. So now, just when I present to the legislature, I like to make sure that you understand, that we understand that the pressure that you're under as the fiduciary body for the state. The commission is not a bank. The funds that we have, we're very appreciative of, and we're very tight with those funds. And you can see on the far left, we put the readiness costs or the readiness funding for our trauma centers at risk. And what I mean by that, you don't get your readiness funding unless you meet certain metrics. And when we started this program, we only had centers meet about 3 metrics because we were introducing the ideas about a performance-based plan. And over the years, that has now increased up to about 22 metrics that you can see there that they have to meet before they can get their funding. The graph on the right, when we started, we only put 10% of their readiness cost or readiness funding at risk, and now we're up to 76%. So most of their readiness funding is at risk. They have to achieve certain metrics. This has been one reason we can decrease mortality, because we're watching the outcomes so closely. Now, just a word, I want to spend just a second on uncompensated care. Most of the focus is on readiness funding today and costs, but through Senate Bill 60, we have to put some funding into the silo, if you will, of uncompensated care, and that's exactly what you would think it would be. That's well defined in SB 60. Or now in code. And you can see over the years, as the uncompensated care costs have gone up, or charges, you can also see our funding's been held constant there for the commission, and there's a big gap as well. We only fund about 10 cents on the dollar for the uncompensated care claims. And if you look at it this way, you can see back when we had the $58.9 million, that was the one-time allotment, you can see we were at about 61 cents on the dollar. We were able to fund, and that has dwindled over the years to about 10 cents on the dollar. So if you put it all together, what are our trauma center costs? We broke it down very simply for you, so you could, have an idea of where this cost comes from. For level 1s and 2s, it's $109 million for all the centers combined. For level 3s and 4s, it's $14 million. So total readiness cost is about $123 million. If you look at uncompensated care, the submitted charges by the trauma centers is, about $659 million. But what you'll note that sometimes, those numbers can be a little hard to track, or may not be exact, or maybe a little inflated. It's hard to tell how you look at things. Obviously, the commission is aware of that, and you can see we only allow 10% of those charges to come through that we will entertain for possible possible compensation, and that would leave us at $70 million. Now, we don't fund that. We're not even close, but we only consider $70 million of those charged. So when I say that we're pretty tight or with our formulas and assessing the system, we really are. There's a 90% cut right off the top of the bat in uncompensated care. So if you put the numbers together, 70 million and 123, the total cost for trauma centers are $194 million. So now what about return on investment? I want to, as we come down the home stretch here, I showed you this slide that we are now better than the country as far as our death rate. We've gone from 16% worse than the national average in trauma mortality to 6% better. So what does that mean in a human factor? That's 1,803 lives saved in 2020 that would not have been saved if we had not have done anything. And I think that's time for a victory lap. But now, switching gears a little bit, we took it a little bit further to see what the financial implications of that would be, since sitting in your chair, you have to decide how to spend the taxpayers' dollars. So if you look at this slide, you can see we looked at of those 1,803 lives in 2020 that were saved. That is red on the far left there. That's lives or deaths averted. You can see that's several $million. If you look at the sort of butterscotch color, that's disability. If for every life we save, there's usually about 2.2 or 3 disabilities that we prevent. And then if you look at the take-home message, the black bar, you can see lifetime preservation of those 1,803 lives. That's about $5.4 billion in personal income. And then if you look at through some fairly sophisticated formulas, if you look at what that would mean to the state as far as tax revenue, you can see it's around $600 million lifetime tax revenue for those folks that were saved in 2020. So that's a pretty strong, or we thought a pretty strong return on investment. We didn't really understand that from the commission, exactly how you all look at return on investment. So we were advised to look at one of the projects, which the Savannah Harbor project, which the return on investment from that shows that it was for every dollar spent about $7.30 return on investment. And our return on investment for every dollar given to the Trauma Commission and invested in the system, the return on investment's about $22.60. So we thought we were on the right track with where we were headed. So what our proposal is, our stabilization proposal, because we are really maxing out of what we can do. This has been, the commission was created in 2007-8, and our funding really hasn't changed a lot. So just focusing on this slide, I won't read the whole thing, but I'll point your attention to the bottom number in bold there, right in the middle of the screen. Remember, I said our readiness costs are $122 million. Our proposal is that the state, that we equal this out to where now the Trauma Commission is only able to fund about 8 to 10 cents on the dollar for readiness costs, and that's just really too low for us to go out and recruit other centers. It's getting more difficult now as we've brought other centers in. That number's continuing to fall. Probably next year when we do our analysis, that 8 cents will probably fall to about 6 cents on the dollar. So it's harder for us to recruit centers to come in because we cannot cover the readiness costs, and it's harder to maintain the ones that we have. So our proposal is that we do a 50-50 split. We think around 50 cents on the dollar is the sweet spot, and if I remember, I've got good data now to show you, but back in the day when we first started, it was 58 cents on the dollar, and that seemed to be a sweet spot. So it's interesting how 14 years ago that number has still sort of held solid. Future state here, you can see now on the left, future state, we have probably between 7 and 10 centers, mostly in rural Georgia, that would be interested in coming into the center. We'd like to go after them more aggressively. And you can see in the future state, we add more dots, we add more color, we can save more lives. And that's to give you an idea how the map might look in future state. So what would the proposal do? It would be a predictable readiness cost offset that allows the trauma centers to better plan for total fiscal challenges. They sort of know really what's in the pot, and when we bring them on, we know exactly what we can fund them with. It allows for system expansion and also to maintain the centers that we have now. And then finally, it increases in funding for rural centers, which was recommended by the American College of Surgeons when they came into our state and did an analysis about a year ago, and minimizes the impact on the level 1 and 2 centers. So I know that's a big ask, so we put one slide in here for your consideration. Again, our job is not to tell you how to work the spreadsheets, but we did put this in, if 61 million is not feasible or is too much of a heavy lift, then it could be in a phased project, and we put this in here for your evaluation. You could go in phase 1, you see listed there, phase 2, phase 3, where you increase the funding over a 3-year period till we get to that 61 million additional funding into our budget. So, Madam Chair, you've been very kind to let me go on for so long. I talked as fast as I could, and thank you very much.
Thank you. We do have a few questions for you. Chairman, go right ahead, Newton.
Hey, thank you for your presentation, and thank you for the work the Trauma Commission's done. I know we've seen a huge expansion even from earlier in 2008 and all, but that future state does look even better. I did have a little bit of a question about whether you're getting what you need. I know right now you say we're 8 to 6 or 10% of the funding that's needed to cover the access costs. Do you know, two-part question, do you know how many, like what percentage are automobile accident related? And second part of that is automobile accident insurance helping out when you need it at a trauma center with trauma activation fees and other things that help offset the other 90% of that readiness requirement?
So great, very sophisticated and complicated and great questions. I'll do the best I can with that. Motor vehicle crashes are a huge part of what we see. Believe it or not, in falls, ground level falls from elderly folks are very common and sometimes even out trump our motor vehicle crashes. But motor vehicle crashes are one of the most predominant things that we see for its mechanism. And then as far as the car insurance or vehicle insurance, it's very minuscule, if I could say. That alone really doesn't fund most of what we need. Certainly it's a help, but those insurances are usually so small in amount that they really don't cover the trauma bills for all the providers and trauma centers, as well as you got EMS as well. So,
thank you.
Chairman Hawkins, you have a question?
Yeah, I know medical CPIs run more like about 10% a year, but how about patient load, the number of patients? I don't see that in here anywhere. Does that not affect your readiness costs also?
Another great question. So we've done an analysis on that, and I could get you the paper, and we actually do some calculations.
Right.
So readiness costs is the things that I have to have where I see 1 patient or 100 patients. All those things in that book, they have a cost, and so that's what that 10 million's for.
Right.
So that's a blanket statement. Now, if I'm a trauma center and it's trauma center A, so there's my readiness costs.
Right.
If I'm trauma center A and I see 1,000 patients and I divide that number, and I could break it down, is it a high-level trauma patient like an alert 1? Is it an alert 2? Is it alert 3? Each one of those for the activation fees that you mentioned have a different cost, okay? Right. So I can divide those numbers into my 1,000 patients, and I can get a charge or an activation fee, or I can get an idea of how much it costs to take care of those 1,000 patients. If I see, and maybe it's I'm just making up, maybe it's $100. But then if I have, instead of 1,000 patients, I only have 5 patients in my center, obviously my readiness costs are going to be huge, but it's really all the same thing. I still have to have all the things to be a level 1 trauma center or level 2.
Right, I understand.
So it's a great question, but it's fun to talk about. But in a way, your readiness costs are still going to be 10 million. It's just how many patients you spread that over. Does that make sense?
Yeah.
But whether I see 1 patient or 1,000 patients, I still have to ante up the 10 million.
Right.
to have all the stuff in place.
Right, okay.
Are there any other questions? I don't see any, and thank you very much for your presentation.
Thank you.
Our next presenter, again, I appreciate your patience, Commissioner Carlson, Department of Community Health.
Two screens. Yeah, it is. I'm trying to get it over on this one. Yeah. Why this is. There we go. All right. Yep. Let's switch it. Okay. Sorry.
Oh, thank you. I know that took a second, but if I would have been doing that, it would have taken a full 11 and a half hours for me to figure that out. So you would have missed your Fat Tuesday celebrations. But Madam Chair and members of the committee and budget staff, thank you for the opportunity to be here with you today to present the governor's recommendations for FY 2025, and enjoy being with you during the amended process. And I know some of this you might have seen before, so I'll try to get to the point on the matter today, but obviously, much like Dr. Ashley said, I don't want to gloss over anything of importance to you and your constituents, so happy to backtrack or revisit anything on here. But again, just a quick reset, as I've mentioned in the joint appropriations and amended budget hearings. Much of what our budget cycle this session and probably beyond, much of what it's centered on is the federal mandate to wind down Medicaid following 3 years of the public health emergency. That's something that all 56 states and territories are going through together at the same time. So you can imagine not only the human resources put forward, but the systems resources put forward as we try to go through this process together and constantly open-minded on ideas and allowing the process to evolve along with our partners at DHS and DFACS, the caseworkers that are on the front lines working these issues. The current budget, I'll go to slide 8 if I may. Slide 8. Again, leaving some of this in for takeaways moving forward. But slide 8 is where we pick up FY 2025 and just a summary of the governor's recommendations. All the programs represented here. And then we'll go into a little bit of detail moving from the tracking sheet. Statewide changes. Obviously, I want to thank first and foremost the governor and OPB and the General Assembly for their consideration of the targeted salary enhancements for the post-certified law enforcement officers, but then also the cost of living adjustments that I know many agencies have stood before you here on slide 10, 17.1. Sorry, my eyes are terrible here. 17.1. Sorry, can't read. That we're very grateful for for the governor and the General Assembly to help us with these matters when it comes to recruitment and retention. But now, as we work through the recommendations and the tracking sheet, I would like to draw your attention, if I may. Many of these are statewide changes that you've seen in other presentations, but if I may, I'd like to go to 1717. Sorry, I'm getting acclimated now. We're off and running. These are positions that were presented in the governor's original recommendation that were our request, and I have a slide devoted to this following, but it's 20 positions to monitor, evaluate, and improve our care management organization oversight. As you know, we are in a season of procurement for many matters, but to include, first and foremost, the CMO contracts. The bids were closed on December 2nd of last year. DOAS had some work to do on certifying a few matters, and now it rests at DCH on our evaluation team beginning this January. That's a process thanks to the open competitive bidding process that ended up with about 10 very reputable national entities bidding on this. It will take some time to evaluate, but we do have evaluation teams in place with subject matter experts supplementing these efforts, given the subject matter of the day. These teams are sequestered, so they're taken out of the day-to-day, the phone ringing, the walk-ins. They're sequestered when it's time to do their work, and they have a pretty tight timeline, but we're trying to balance that, a responsible timeline, but also recognizing the gravity of the exercise. We're trying to give them the time and the space to do this thoughtfully and deliberately, where we're mindful of our calendars, very mindful of our calendars, but we're not trying to check boxes either. These 20 positions will go to what I've kind of said in past hearings, that when we issued the RFP for the CMOs last fall, there's a lot in there that we're asking CMOs to do, new things. There's a lot of levers now afforded the state when it comes to holding people accountable, whether it's quality metrics, contract compliance in general. Here's a better slide for the actual positions that are contemplated in that line item. But when I look at that RFP, I do recognize there are a lot of things we're asking the CMOs to do, but I look at that and see a lot of things we're asking DCH to do and do better. I know that more has been expected of us in years past, of holding people accountable, making sure that everyone's transparent and all the information flow back and forth. So I look at that as something that we're really focused on making the department a lot better in this space. So when you look at these positions, we asked the governor's office to consider, and grateful for the recommendation, and humbly ask for your support here too. It's a lot of data analytics and trying to step into the new age, along with the dramatic systems overhaul that's going on. I'll have a slide devoted to that too, that we're basically trying to modernize the department. The PHE put a lot of procurements on hold, and now all that's coming to a head at once, which makes it interesting, but there's a lot of opportunity in that. We hope to have a data analytics operation at your department that has us smart on what's going on in the field, that knows what's happening before we ask the questions, so to speak, that also can help us make data-based decisions when it comes to quality metrics and things we might want to pivot to as a state. We can get targeted in our priorities, where yourselves and the governor's office, when you weigh in on matters, we can hopefully target that and measure that and use a lot of the rebates or withholds to have levers available to hopefully motivate and get people to comply with whatever your priorities are. But we recognize that's an ask of us as your department as much as it is an ask of those organizations. So this is a very important matter to us. I think it'll make us better as we perform these new round of contracts. Moving to the governor's recommendations, again working from the tracking sheet, you'll see several matters in dentistry and pharmacy, investigative software addressed in 1725, as well as we move to, sorry, I'm trying to bounce between a couple of different screens here. Pharmacy has cost of living adjustments as well, and also several different matters. I believe there is one place in here I'd need to draw your attention to. Software, that's in dentistry, 1725 on the investigative software there. Moving into healthcare access and improvement, there's one item that I know kind of jumps off the page. There's a reduction of $4 million, but that's because we have executed, that's removing one-time funds that you approved last year for several programs that we're proud to announce. Health Stabilization Grant. We're executing both tracks right now, but we are able to administer those grants and get those $4 million awarded to no particular order, but Archibald, Colquitt Regional, Coffee Regional in Douglas, Georgia, Coffee County, Meadows Regional in Vidalia, and Fairview in Lawrence County. All recipients of these grants, but those funds have been expended, so we're removing those one-time funds. And also, while I mentioned the Office of Rural Health, who administers these grants, we've just named, week before last, a new state director for that office, which I know is important to so many of you. Joel Presley comes from Tift Regional and was actually a customer of those grants, the Rural Health Stabilization grants. So he knows that process, knows the people involved there, both regionally and at the office itself. So we're very grateful that Joel joined us just earlier this month. Also, 1744, you'll see $50,000 for excuse me, I'm trying to kind of find my spot there. In 1744, you'll see something that was addressed in last spring's budget with lupus education. That's adding it back in the amended and representing it here. Another item that I'd like that we're very grateful that the governor's office and OPB put in their recommendation, and something we humbly ask your consideration for. Another priority, in addition to the CMO performance management contract compliance piece, was HFRD, our Health Facilities Regulatory Division, which is basically our surveyors. This body has worked on those issues with us over the years. As you'd imagine, it's as integral a function as our department has, but also, as I think you'd imagine, it can be the most challenging to recruit and retain for. There was some modeling that sought out Louisiana as a salary for the region, a comparable state that made sense for us. That was our target. So we are trying to bring that in line on a competitive basis to keep everyone current, to keep in compliance with CMS, but it'll bring forth an average increase of $4,620 for these surveyors. Many of these work from the field. They are oftentimes in hotels and traveling great distances as they do these multi-day surveys. So I know from past years where surveyor matters were contemplated, I know it's important. Item to you. I very much know it's an important item to CMS, and we're trying to keep this division very current, very strong, very healthy, because we know a lot of providers in the field rely upon prompt surveys for so much. Moving to slide 15, as we begin to look at programs, starting with the aged, blind, and disabled. As you'll see in 1771, there's $68.4 million in growth based on projected utilization. There's much to be made about, and we'll discuss it here, within the limb population, a lot of the fluctuation with redeterminations. On the other hand, though, ABD, that population is relatively stable as far as individuals coming on or off the Medicaid rolls. But what we do see, as you know, it's a population with very acute needs, and between the cost and the utilization, you often see significant growth in this space, and that's reflected in 1771. Below that in 1772 is a bit of an exercise, again, with the public health unwinding. It's restoring funds following several years of enhanced FMAP during the PHE. So as this has been winding down, the enhanced wind down quarter by quarter over several years, back to January 1 of this year, we're just now back to kind of our traditional FMAP. So these funds are kind of reconciling those ledgers from budgets dating back to 2021. 1773 is a annual kind of hold harmless exercise with our Medicaid Part B. But then in 1774, this is the more conventional, traditional recalculation of our state FMAP. So not to be confused with 1772, which is the true up with the enhanced FMAP over the PHE. 1774 reflects where Georgia will land on the current FMAP, which will increase from 65.89 to 66.04. And again, this is an exercise that's done every year based on population and economic factors. 1775 is the Medicare Part D clawback. Again, another annual adjustment for those dual eligibles. And we actually have in our takeaway slides that may not necessarily be covered today, we have some additional information on those calculations. I know they can get very, very detailed, but it's a process that all states go through. 1776 reflects an update to the current nursing home cost report, which is $118 million. And again, the previous rebase was addressed in the amended, and this is the current year's policy 2022 cost reports. The next couple of lines, excuse me, let me kind of go through. The next couple of lines here, and if you back up, I didn't mean to slip over a couple of slides. There's several relating to the provider fees, 17.7, 8, and 9, an annual exercise. But as in this very room, I guess, a week ago, Chairman Blackman first introduced that provider fee is sunsetting. So there is legislation this year hoping to extend that provider fee. It's utilized by many providers and is the backbone of many programs, the DPP programs and others. So it's a very significant piece to our financial modeling across the board. But what you'll see in 17.7.10 is something that I know, and 17.7.11 is something I know that's been important to this body as we look to fund and implement several rate studies that have been set forth in legislation past sessions. In fact, we devoted a separate slide to this. Sorry for jumping the gun moments ago. But these were reflected in the governor's recommendation. A very nuanced, choreographed effort with our partners at DBHGD. And we appreciate OPB's leadership on this issue as we try to see through legislative intent and something that was signed into law by the governor on several rate studies over the years. We know how much this means to the provider community. And to stay, to try, and I was speaking with stakeholders earlier today, the DCH board agenda for March will have our initial adoption of several of these rules and rates to go ahead and try to get things to CMS in a responsible manner where they can be in CMS's. May would be our final adoption at the DCH level, and then CMS, even if they take some time to evaluate and approve, if we get it in that time frame, it will in fact be retroactive to 7/1/24, which is our target. And obviously, if it's the will of the General Assembly to change any of this, we will reflect that in our board matters any way that ultimately is the law of the land. But we're trying to we don't want to get caught flat-footed, and know it means a lot to providers to meet that 7/1 effective date. And again, kind of a leave behind. I know these get very nuanced, but just a rundown of all the different waiver programs contemplated here and just in general. When I used to work for the National Guard, I remember coming home and telling my family that these people use acronyms to explain their acronyms. Healthcare kind of rivals that, so I think it behooves us all to have what I call the quarterback wristband with kind of my cheat sheet on a lot of these programs and who the eligibility behind all those. But again, if you toggle between the rate studies and our cheat sheet, I hope that that helps you. Moving on to slide 18, which is low-income Medicaid. Again, going right to it, 1781 will reflect a change in enrollment based on our projected utilization enrollment of Medicaid moving forward. That's an exercise that we spend a lot of time on. We're working with actuaries and try to understand the activity in the field to give all appropriators and the budget offices responsible numbers that they can work from and plan towards. But this is a changing hourly, much less daily, much less monthly as the redetermination process moves forward. Again, 17.8.2. It's, again, you'll see the same exercise, restoring funds related to the enhanced FMAP that the state experienced for some time. 17.83 is, again, the adjustment to the FMAP we discussed earlier. And again, begin with 17.84, some language on the provider fees. Peach Care, 17.9.1, we actually expect some growth in this as opposed to LIM, and that's reflected here. And again, some of the similar movements with enhanced FMAP and FMAP. All right, just make sure. And again, this is the same information, but again, for your benefit beyond this committee hearing, just columns beside each other for your comparison. However, it helps you digest this information to look at some of the trends across the different programs in the bottom line, state funds there in your bottom right. Moving to SHBP, and again, I always like to say this before I move away, 97 to 98% of our entire budget is devoted to benefits. So we do our best to make sure that dollars get into the field and get to providers and get to families. State health benefit plan. There's been an increase to the employer health care contribution PMPM for non-certified school employees to match the PMPM for certified school employees effective January 1st, 2027. That's been something that's, I believe that this body initiated a phase-in to that process, and this is only extended by a year. It adds an additional step to the phase-in to reflect the additional increases to certified school personnel also. I think this slide is helpful. I would think on behalf of all state employees, the General Assembly has really helped keep this program solvent, along with all the trends going on in the field that we all know about with utilization and cost of services. But if you can see 2024, when it comes to certified personnel, there are some trajectories that we weren't too sure about in OPB by kind of changing how the various stakeholders, certified, non-certified, active employees, by bringing some uniformity to those contributions, we have hopefully, should the General Assembly see fit, bring some of those expenses and revenues into alignment, as you can see with 2025. There we go. That reflects, that's current state, and that reflects should we enact the budget before you now. If it helps to toggle in that manner. And that is, as it says there, to increase the employer health care contribution PMPM rate for certified school employees and leading assistant teachers to $1,760 effective July 1st. And this is what is the last slide. No pop quiz on this, but I always like to, again, kind of with the system side, this often shows up in appropriations process as you do help us fund working with CMS, oftentimes at a 90-10 match rate. as we overhaul a lot of these systems. But all these, for example, Gateway is our integrated eligibility system. It's integral to the redetermination process. It is something that will be up for procurement in years ahead, but we're trying to balance a responsible, steady state while we plan for the way ahead with not only CMS but FNS for SNAP and TANF programs and others. And you have several other large systems overhauls, but the result of this, it takes a lot of resources going into it, but due to all these procurements taking place over the next 5+ years, again, as I said, with the data analytics and the CMO performance management effort, it will result in a modernized department. And that's something that a lot of states are going through, and we're committed to doing it, and grateful to the team for helping us see it through on a multi-year basis. So thank you for your patience as I toggle between sheets and screens, but that does conclude our initial overview. And obviously, Madam Chair, I'll yield the floor to
You
questions.
do have a couple questions, and
Yes, ma'am.
I do have one. Why are we postponing the information for the non-certified till 2027?
That was a phase-in. It's not postponing, it's phasing in over
Okay.
time, so it isn't just an initial one-time.
Okay,
time
so
hit.
we're
Yes.
just increasing a little bit
Yes,
over
ma'am.
the years.
The trajectory did end with, I think, 2026 previously contemplated, and just bringing another year just kind of helps everyone kind of.
Okay, it really has to do with the comment about the managed care. I'm very grateful you have a department that will be looking into this, because for me, I was very concerned. I want managed care, not just managed cost, particularly for the ABD. These are comorbid, and I want to make sure that they get a full controlling of their care.
Yes,
That's what I'm
ma'am.
looking at. But
Yes,
you do
ma'am.
have several questions.
Yes, ma'am.
Let's see, who is it that has it? Okay. Chairman Petrie, you have a question?
Yes, thank you, Madam Chair, and thank you, Commissioner. I appreciate your strong leadership and appreciate this budget, I have to tell you. A couple of questions. I won't be too lengthy here because we've had a long day here, but I do want to mention a couple of things. The chair lady just mentioned, when you mentioned earlier, these 20 new positions. That's excellent at a time when we're actually going to be expanding our CMOs into the ABD population. So I guess that'll be helpful in that regard as well. Your comment on data, again, excellent. I think that we've got to make sure we know how well we're doing. And my hope is that with those, with our new managed care for ABD, we're going to have some quality incentives there. I know you and I have talked about that.
Yes.
I think that's your plan.
Yes, sir.
And
Very
that's
much
the only
so.
way to track that. So I'm pleased to see that. I would encourage the department to, I know you're going to do this, but to strongly reach out to providers. It's new to them in the ABD world, and anything y'all can do to help to continue to communicate with them kind of regularly. It's going to be a long process.
Yes, sir.
But all of that will be very helpful. I wanted to also tell you, Commissioner, that very much appreciate, and I have a question for you here. I appreciate the provider increases that we know are so desperately needed. And the CMS, so typically CMS is our holdup when these are implemented. And you just gave us a great timeline that looks like we'll have done all we can do by 7/1. Do you expect CMS to maybe be a little more efficient than they've been in the past? Because we've had occasions where they've taken well over a year to approve these things. What are your thoughts there? Thank
Yes,
you.
sir. Crystal ball isn't batting 1,000 in this space, as you'd imagine, but I'd like to think it's multi-agency. It has consensus over several years of legislative action, and I think it's ultimately intended to shore up a statewide network of providers. So it will be scrutinized to some degree, which is their job. There'll be a series of questions, but it's our commitment to get it up there and to hopefully proactively account for any questions we might foresee and have a quick turnaround on our end. So thank you. Yes, sir.
Representative Hughley, you have a question?
Thank you, Madam Chair. Thank you, Mr. Commissioner.
Yes, ma'am.
I am wanting to talk about redeterminations. Of course, you saw the big article in the paper today, and I'm particularly concerned about children coming off the Peach Care rolls. What are you doing with that? And is there anything innovative that we can expect coming along the line to help with that?
Yes, ma'am. That's obviously something that weighs heavily on us. I'd like to say a couple things. We have improved this process from when we started in April has been constantly evolving, improving. For example, the ex parte process, which is optimal for all of us, it's a more of an automated approval. When you factor in the SNAP and TANF cases together, just with the same eligibility worker doing all of them, first of all, we sought a waiver for the federal government to bring those redetermination dates in line. So if your date for a SNAP is coming due for a family, we go ahead and reevaluate all those at one time, and have incorporated a couple of technology changes that if you are eligible, a family would have to opt out of those instead of making sure they opted in. So if we see you're eligible, we try to go ahead and check as many of those boxes as we can on the front end. But in addition to approving the express lane eligibility portion of that, the ex parte process, when we started going in April and May, was in the 20s and low 30s. Our December and January data, when you take in the SNAP and TANF cases, the whole process, our ex parte rate now was around 62%. It's some of the most recent numbers. CMS, just their structure, reports a lot of times just on the Medicaid cases, but when you look at caseworker X, their workload, we are now, for the last month, reported about 62% on that automated across all those lines of effort. So we're constantly improving. We have several outreach events, many of which have been generated from legislative interest in local areas. For example, we saw that looking at the data, manipulated the data into a heat map, and saw that Gwinnett had higher procedural terminations at one point. And so we're working with several advocates and others on putting together a Gwinnett event. Thank you to Commissioner Brose, who has been offering to put DFACS caseworkers on site, which can adjudicate it right there as opposed to just another thing in the pending stack for both the family and the caseworker. So we're trying to kind of go to the fight where we can. There's several events that I'm aware of that are going on in Gainesville, Albany, several in the metro. Mr. Thurman in DeKalb just completed his second event. So it's a process, but I think it's one that we're improving, and we've been open-minded to pretty much anyone's ideas, regardless of where they were coming from. So.
What about what they're doing in, I think North Carolina is doing something innovative in order to keep the children on the rolls?
Yes, ma'am. I know we try to track what other states. Our process with the ex parte was where we were really trying to improve. So if we're doing ex parte right, a lot of the family won't know the difference, so to speak. Enrolled yesterday and enrolled today. Another thing that we have going for us is that the federal government and the Consolidated Appropriations Act passed recently, CMS inserted into that bill that children between 0 and 19 have a year of continuous eligibility. What that means is when they are granted eligible, their circumstances won't be reevaluated for a full year. So in other words, if that family's income status changes or the number of people in their family, if anything changes, that data set isn't impacted immediately, or we're not alerted immediately, and they're immediately deemed uneligible. If July 1 is your redetermination date and you're deemed eligible, you keep those benefits for a full 12 months until your next date, next anniversary date. So some stability, hopefully, for the families.
My last thing, we had a redetermination event in Columbus, so I want to shout out our Columbus DFACS team that came. They do a good job.
It makes all the difference in the world when their resources are limited and when they're able to be present. And I, again, thank you to Commissioner Brose and the DFACS team. When they can be present, it really makes a big difference. So thank you.
Yes. Chairman Newton, you have a question?
Yes, thank you, ma'am. Appreciate your presentation. I had a question. I've heard from some struggling, let's say, skilled nursing facilities in area, kind of to follow up on what Chairman Petrie mentioned. And I know we do have a provider fee program from that. I know since the public health emergency, a lot of the occupancies went down, and sometimes they went down below the break-even point, and so they're really struggling. Is there any flexibility in the provider fee arrangement to allow for ones that would be devastating to a community to lose? And there may not be, but I'm just wondering, are there any things we can do about ones that are struggling? I know the provider fee is at least I know overall it's a benefit long term. Some of these might not make it through the short term if we
Yes.
don't find a way to help.
No, I appreciate that question. You're right. A low census can be detrimental to with the high percentage of Medicaid that they have. There's really no other revenue streams for them to turn to sometimes. I would say when it comes to skilled nursing, they did, credit to them, had the foresight. They have actually in years past sought a waiver to basically max out their provider fee. They are now offering up the maximum federal amount allowed for their provider fee. So credit to them having the foresight to do that. I do think sometimes there are different, whether it's UPL or different kind of avenues for them to consider. I'll say this, we try to be mindful of that, especially they're caught up in redeterminations too with existing people, but also new applicants, so a backlog there really can be detrimental. So we've tried to address some things on the redetermination side to help from a cash flow perspective on eligibility. But we're always mindful to try and keep all constituencies, keep it equitable across whether it's children or nursing homes, just to keep an equitable process. But obviously I know how detrimental, especially a rural facility, that is only facility in 2-3 county area, how detrimental that'd be. So
I appreciate you knowing about it and also hopefully agreeing to look into it and
Yes,
seeing
sir.
are there additional things, would they require legislation or appropriations? Thank you.
yes, sir. Thank you.
You have another question, Representative Buckner?
Thank you, Madam Chair. I have a question in regard to the department being able to support potentially a rate increase for like our pediatricians with the gap waivers in parity with the other waivers and
Yes.
other increases.
Yes, ma'am. So no, thank you for that, and credit to the budget offices for always trying to make us aware of thoughts going through the assembly. We try to have all those modeled out, the codes, the utilization. Try to work with the budget offices to be in a position to execute. As long as the policy and the appropriation can match, we will faithfully execute the best we can. And so we thanks to the budget office, we don't get caught flat-footed. So we'll try to execute the will of the General Assembly as best we can. So, but thank you. I'm aware of that request though. So we're trying to model that out real time.
Thank you. You have one more question, Representative Bennett?
My lighter, oh, it's working. Good afternoon. Thank you, Madam Chair. Since we're on the conversation about provider rates increase, I want to know if it's being considered for the physical therapists, occupational therapists, or speech therapists at this time.
Yes, ma'am. We've had requests in to model out those codes as well, both in the community and we've gotten a few requests, in school settings too. So we're trying to be current and give responsible information to your analysts and legislators that make those requests. So.
Thank you.
Mm-hmm.
Thank you, Mr. Commissioner. We really appreciate your sharing
thank
this
you.
information. Thank you very much.
Yes, ma'am.
Our next speaker will be the Georgia Composite Medical Board.
I will pull up your PowerPoint and then I will step to the side.
Thank you. If you would introduce yourself.
Certainly, I'm Jason Jones. It's my first day as executive director, so bear with me.
I wanted everybody to recognize that.
Kimberly.
I was going to say, exactly. That's why I held off. So we appreciate your being here. And I get it. It's your first day. You've got a full plate, and we appreciate your being here.
I'm gonna jump right into it, so.
Please do.
Thank you all for having us here. Again, it's my first day, so to bear with me, but I've worked with the medical board years past as an investigator, came back, and now hoping to lead it into the right direction. But of course, the medical board, what we do is we license medical professionals, we regulate that profession through compliance, and then we do investigations on different offenses. So, maybe against the Medical Act or the Pain Management Act. So we have 16 board members, 13 physicians, 2 consumers, 1 physician's assistant, 35 staff members, and we have 7 post-certified law enforcement officers that work with us as well. So the license count, licensing and regulating authority, we have 62,355 licenses as of today that we oversee, and that's all the listings of it. Of course, physicians are the number 1 licensee that we regulate. Respiratory care professionals are the second, and then it goes from there into other professions. So during fiscal year 23, the board processed 7,433 initial applications and renewed 26,194 applications, which seems to increase as time goes along. So, and the board also received 1,964 complaints based on these complaint categories, with let me see, unprofessional misconduct being number 1. It looks like. So it varies with the misconduct on kind of what our investigators look for and what our board members look at and go through. So the board's appropriated budget in fiscal year 24 was $3,151,410, which is all salary and fringe benefits for the agency's 35 staffers. During FY 23, the board actually collected $7,514,792 in licensing, renewal, and enforcement fees, which goes to the general fund. The board keeps all administrative fees for its operating expenses, and no state funds go toward our operations. So this is the meat of what we're here for is the budget, and 17.17, of course, is where we're at. Point 1 allows for the increase in the cost of living, the 4% for the state employees that Governor was gracious to give us. 17.2 reflects an adjustment to agency premiums for DOAS administered insurance programs. So that's just additional funds for that. Point 3, increased funds for merit system assessment billings. Point 4 is the additional $3,000 for our post-certified officers that was also added to the cost of living. And what we've, point 5 and point 6, we'll be using existing funds to replace 3 vehicles for our investigators. They have aging vehicles that probably cost more to stay on the road than it needs to be, so we're replacing that, and also existing funds for 1 customer service specialist with a budget of $3,282,148. So what the medical board has done 2022-2023 is revised policies for electronic receipt of application supporting documents, began offering electronic copies of licenses, implemented patient safeguards under House Bill 458, started publishing quarterly newsletters to kind of, I guess, give more insight of what's going on with the board, which we will continue and probably improve upon. And then they moved over to the Twin Towers from 2 Peachtree. So I guess that was an expense they had. So our outlook for 2024, and this is just a bit of what we want to do. I know I have a lot of things that will probably come as I look into things and start figuring out what we need to progress in. But we're finalizing implementation of data collection under House Bill 1013, adding the residency training permits and APRN protocol applications to the medical board's online portal, requiring upload of all supporting documents at time of application submission for all applicants. That way, we'll have it right there to say, okay, this is all here, we're good, and we can expedite those licensing for those medical professionals. And then implementing all remaining recommendations from 2020 Department of Audit's audit report. So we'll be working on all that through the year and making sure that we hit all those key points. Try to make it quick because I know you got a long day, and there's more to come. So any questions?
Thank you. You do have a couple questions.
Yes, ma'am.
Chairman Petrie, you have a question?
Yes, thank you, Madam Chair. Director Jones, so congratulations on your new position, and
Thank
you are uniquely in a department that you're doing pretty good there. So you're bringing in $7.5 million, and we're budgeting $3.1 million for you. So that's a pretty interesting agency to
switch
run,
those.
isn't it? Y'all are doing pretty well. Y'all are doing pretty well. So on the licensure, I just wanted to call attention to, great trend with the initial applications. Overwhelmingly, these are physicians on your list, so
Yes, sir.
it looks like we're moving in the right direction
Yes, sir.
with physicians in this state, and I just wanted to call that out. That's pretty impressive. I'm glad to see that. Obviously, we know we've done a lot of work here over the years trying to keep pushing that forward, so
It'll keep improving.
welcome. Thank
Yes,
you, sir.
Thank you.
Let's see, Chairman Parrish, you have a question? Oh, I'm sorry. Wait.
Ms. Jones, thank you. I know it's not really a fair question for you since you're brand new here, but a lot of us are receiving complaints about the turnaround time on license renewals, protocol agreement renewals, and this sort of thing.
Yes.
And I guess in your outlook for 24, you've got some things in there to address that. I guess I got two questions for you. One is, do you have the resources you need to implement all this so we don't continue to get all these calls we're getting about when it takes so long for us to have this done? And if not, can you share with us what we need to do to make sure you're given what you need to do the job? Because as was pointed out earlier, the fees that you collect in the licensing renewals should be adequate, and it's on us if we don't give you the proper money to do that. So
Yes, sir.
do you think you've got the people? Do you think you've got the money in the budget to do what you need, or we need to know what we need to do?
No, sir. From my initial assessment, we don't have the people and we don't have the technology and the processes in place to do that. And we would need more money to do that, to be able to have the right technology to advance everything, to make them quicker, to go through everything, and the right amount of people to process those. Right now, our enforcement specialists have about 200 complaints apiece, and to me, you can't work. I'm an investigator by trade. The average caseload should be about 25 for folks to be able to adequately work that. So I know they're well overworked and need more people to be able to take care of all those cases. And also our investigators, they have more cases, like a 70 apiece caseload. And we still have some in the backlog that we can't even look at. And licensing as well, there's so many coming in with very limited resources. So having more would definitely help, but I would have to kind of look and see exactly what we would need.
Yeah. Well, Madam Chair, we hear about the shortage of healthcare workers for the workforce. And I think one of the problem is if we could get some of these people licensed more quickly.
Yes, sir.
And get these agreements agreed to, the protocols, so forth, and turned around so that these people could go to work.
Yep.
Quicker, that would help. And I'm hoping that, Madam Chair, we can try to receive some information about what we need to make sure you've got the resources you need to do that. And then if it doesn't get done, it'd be on you, it wouldn't be on us.
Yes, sir.
Thank you.
I'm more than willing to do what I need to do.
Well, thank
So,
you for your help.
Thank you. I appreciate you.
Thank you. One more question, Representative Hughley?
Thank you, Madam Chair, and congratulations, Mr. Commissioner. I'm looking at these 1,964 complaints, but you don't say how they were resolved. And you spoke a little bit to it with Chairman Parrish's question. So my question. How were all of these 1964 complaints resolved?
So we do the, administrative process. We'll have consent orders that will go out. We can, if there's a valid complaint and substance to it that we can prove, then there can be, consent order done through the AG's office, and we do, and the board will decide on that. And they can suspend a license, revoke a license, or probation on a licensee. So, or they can fine a licensee as well through all that. So, I don't know the numbers as far as on all those, what happened, or if they're still in investigation, but I can get you that and kind of give you a better rounded figure on that.
Chairman Newton, you have a question?
Yeah, just a quick question. I just first wanted to say welcome again and thank you for jumping in here. Your background as an investigator is actually encouraging. I know those complaints are out there on providers and of all sorts, including physicians, and I know Georgians expect them to be held to an incredibly high standard. And,
Yes,
and I really appreciate you pointing out that you may need additional resources, maybe out of that gross figure that you refund back to the state. I do look forward to hearing from you, if you don't mind, on how you can get the tools and the equipment that you need, because I do think that, as Chairman Parrish said, the number of providers that are a little bit dissuaded from even applying necessarily, or the delays that are incumbent in that could make a big difference to our physician workforce. So thank you for jumping right in and actually knowing some good data and knowing what to ask for. Thank you.
Drinking out of a fire hose, but I'm used to it. I'm good at it. I can adapt. So.
Keep it up.
Thank you.
Thank you. We appreciate what you do, and we look forward to hearing from you with some details which would be helpful to the department. And thank you very much.
Thank you. Thank you all so much.
Okay. Our next will be Dennis Trufton with the Drug and Narcotics Agency.
Good afternoon, Madam Chairman and
Thank you.
members, and thank you for asking us to come speak about our agency's budget. We are the enforcement agency for pharmacy and prescription drugs in the state. We enforce the criminal and the regulatory, as I know I've mentioned to most of y'all before in doing our other budgets. This will be short and fairly quick. We're a small agency, but if we go to the tracking numbers on your document, the first 5 items there, 17.18.1 through 1718.5 are the statewide governor's recommendations to include, which includes that 4% suggested cost of living increase, as well as increase for post-certified officers. Out of our 19 employees that we have at the Georgia Drugs and Narcotics Agency, 15 of us are post-certified officers. So the biggest bulk of our budget is certainly to take care of those personnel, but that is greatly appreciated. I don't know if it's ever been a good time to be a cop, but this certainly doesn't seem to be like a good time, and that would be very helpful to, because my agents are also pharmacists. Every agent, and including myself, have been a pharmacist for too many years, a lot of years. And so they are pharmacists as well as peace officers. The other items as we go down the list, 17.18.6 is 2 years ago, the legislature, you folks allowed us monies to get a new data management system, which was tremendous. We are in the middle of implementing it now, and kind of going to what the gentleman said earlier, that data management system is going to give us the ability to provide much more quick data and where in Georgia we need to do different things and certain things. So, but that was the increased cost in the yearly maintenance fee, that $21,000. The next item, the $35,000, which is 17.18.7, is to provide tablets. My agents, with this new data management system, will be able to utilize these tablets and to do the inspections. And we do about close to 4,000 inspections a year with my agents in pharmacy facilities. If it's a licensed facility, then we go in there and do an inspection to make sure they are, attempt to make sure if they're complying with pharmacy laws and the Controlled Substance Act here in the state of Georgia. So that would just bring our equipment up to where it should be so that, again, everything right now is paper. Those inspections are done on paper, signed on paper by the pharmacist, and brought back to the agency. I know it's not funny now. So that's tremendous for us. We just, for the future, that's going to be great for the agency and the people in the state to provide that information. So that would really bring us to a good place to have the modern equipment in that. And like I said, we do about 4,000 inspections. We assist the pharmacy board with their application. So every application that goes through and receives a pharmacy permit, my staff also reviews that. We do background checks on those and background looks for people. So y'all graciously allowed us 2 new agents last year as well through the legislature, and those folks are hired and trained. And now, last one, we are at full load now for funded agents, and my last one starts April 1st. In fact, he's looking forward to spending 12 weeks in the academy. And so I just think we're in a really good place, and these enhancements from you folks will go a long way to keep us in a good place.
Thank you. I, for one, look forward to seeing reports when you do have some out of your new system to see how efficient our pharmacies are. And I don't see any questions, so we appreciate your information and look forward to those future reports.
All right.
Thank you.
Folks. Appreciate it.
Thank you. Our next would be Dr. Toomey, our Commissioner of the Department of Public Health. Welcome, Doctor. We appreciate your being here.
Thank you. And this is worse than going after lunch, going before dinner. So I thank you for your patience and really hope I can expedite things. But many of the things I will be presenting will be familiar to many of you, and some will be a little new. But I'm looking forward to our discussion and look forward to any questions you may have. The first 2 slides in front of you, so that we don't have a slide deck, we just have some printed slides. It's something I've used every year because it's so, to me, so illuminative of how unique and unusual our department is. 18 health districts, 18 health directors who are state employees, 159 county health departments. And with this, who are quasi-hybridly independent. And within that structure, we work as a team. And I think that's what's really important. For us to be effective, whether it's for a pandemic or for maternal and infant health, we need to work as a team. And that's what's kind of important about this presentation today. The other thing I want to point out that's not unique to us, but kind of unusual, is about 50, in the next slide you can see in those pie charts, 50% of our budget approximately is federal, and 50% is state funded, but almost, more than half of that state funding goes also to those counties. And I think that, again, is reflective of the fact that much of the work we do supports counties either through federal or state dollars. And so that's the lead-in to the actual governor's budget request. And this, in the 5 years I've been here, or 4 years, this is the best budget I've been able to present, so I'm very thrilled about it. Many thanks to the governor for the recommended changes that you heard from everyone. I just think, again, for us, it's particularly important because not only will it add these additional employee benefits to the state staff, but also to the county board of health staff. So that's 4,300 county employees as well as 1,100 state staff will get that salary increase. And so 86% of our funding going to the cost of living adjustment will actually go to county staff. So I think that is important because they are the boots on the ground for us. Then moving into the next, the rest are identical, and I think is redundant for all of you who have been here all afternoon. But the other thing is just going into the recommendations. I think we can quickly dismiss the things that we were able to reduce for efficiency. No impact on our services at all. We had some additional funds in past budgets for lead inspectors and equipment. We used that efficiently. We were able to hire the inspectors, buy the equipment, had some leftover funds. We can put that back, into the hopper to be able to redirect to other activities. And for the telehealth equipment, I just want to make clear, we are not reducing the telehealth program in the least. In fact, it's just the opposite. We're expanding telehealth activities. We're looking not only to use it for clinical work in HIV, but also perinatal work as well, as babies can't wait. But we did a very, very good inventory. We found that we had a lot of additional equipment that was not necessarily appreciated in some of the districts. We were able to consolidate that. The telecommunications costs are lower now than they were when this network was originally developed. So we were able to save some money there and kind of redirect that to an efficiency which can go to improve other services. And this may be a little change for those who are at the joint budget, because you may remember Will and I had a sidebar because I skipped around, because I thought it made more sense to put all the maternal and infant activities together to see how they all fit together. And there actually was a thoughtfulness about how we were doing our budget. And so for this, it may look a little different than what you remember. But if you look at the $314,000, that added to the existing funds that will be continuing over will lead to an increase, $1 million increase in our home visiting project, which to me is our most important maternal mortality, infant mortality prevention activity we have. And I'm thrilled about the fact that we've been able to pilot it in several districts, both Waycross and Albany. No, Waycross and Columbus. And no, Habersham. I'm looking at the map in my head, Waycross and Habersham. And in doing so, we are looking for the opportunity to expand with these additional dollars to 13 more counties. So starting with the 21 counties, moving an additional 10 counties. And obviously, if you, as I was asked before the budget was processed, do other counties need this? And the truth is, every county could use an expansion of the home visiting, because it is identifying high-risk mothers, either have had previous high-risk pregnancies, who have high-risk conditions, who have high-risk infants, either through substance abuse or through other medical conditions, and doing medical monitoring, doing high blood pressure monitoring, social service monitoring, mental health monitoring, and with community health workers from the community coming in, communicating with nurses, and in some pilot projects in Augusta, actually working on some of the medical monitoring by telehealth. And so these are some really innovative projects. And I may have mentioned to you earlier that the federal government, the HRSA people that fund maternal and child health projects, reached out to me for a visit about these projects, because they are innovative and unlike what's going on elsewhere, because of that comprehensive approach. And I'm really thrilled about that. And think we have Georgia has a lot to show others about how we've conceptualized this and are implementing it, and continue to do so with your ongoing support. And then several of you know more about newborn screening than I do, and I will acknowledge that because of your interest in this area. This is a program done within our public health laboratory on Claremont Avenue here in Atlanta. We test every child at birth for a number over 30 metabolic and other health conditions. And we have a committee that identifies those recommended tests. These are things that we can treat if identified early. And they have made the recommendation to add GAMT and MPS too, which I can explain later because I can't pronounce them easily without a teleprompter. But they are preventable infections if detected early, and although not very common, are something that we can treat lifelong complications or even prevent death. And so it is something that was added by the committee, and we look forward to being able to add this. Remember, it's a cost-neutral addition because we charge a fee for this at the hospital level, and that will eventually pay for itself, but you need to jumpstart the process and at the laboratory. And the last MCH initiative that we have, and am I okay for time-wise? I'm just watching, I'm watching the time.
Yeah,
And,
go ahead, you're fine.
Hearing everybody's stomach growling, and I understand, but the congenital syphilis was something I talked about in the original budget meeting. I could hear the gasp from the audience. I realize this is not everybody's favorite topic before dinner. I will say that we have seen a shocking increase, fourfold increase in syphilis among women over the last year since the pandemic, and congenital infants, congenital babies born. 100 babies born every year for the last several years, which is, again, shocking in Georgia because this is treatable with penicillin, if found early. And over 17 of those infants had, died. I mean, this is not in addition to the 17 with congenital syphilis. 17 were born dead or died shortly thereafter because of the syphilis infection in the mother, which is absolutely treatable. And I think this is something we're seeing nationwide. This is something we've seen certainly elsewhere. It's something that we saw here in Georgia in the 90s. But to see it come back with this kind of intensity is really disturbing. And this is the time to act. We can do this now, particularly as we begin a consolidated full court press on all these other MCH issues, including home visiting. In rural Georgia, some of this is related to methamphetamine. Some other areas, it's related to some other challenges. And I've talked to Commissioner Tanner about this because this is how the mental health piece really needs to fit in with the maternal activities, because make sure that there's substance abuse treatment and other available treatment for these women before they and as well as penicillin, before they actually have these congenital babies who may die. And ironically, this morning I spent the day with the health directors at another meeting, and I was unaware of how many of these babies look normal at birth and yet have underlying conditions that include bone disease, brain disease, neurologic disease, heart disease, shocking, all preventable, or blindness or eventually deafness. And so with that, this is I'm laying out what I know is an uncomfortable problem, but one I think that we can address even as we begin to address these other maternal and child health issues in a very comprehensive and aggressive way. Moving right on quickly, the budget recommendations for the governor included restoration of funds for the Clayton Health Director position. That was something that was reduced in the budget reduction, but we recognized that that was not really a good move at the time or now. And so we want those positions to be at a full state funding. And we have a good person in place, and we're just grateful that the governor added this back to the budget. The other piece here, the RSS warehouse, or our emergency preparedness warehouse, is something that has all of our emergency preparedness equipment, the masks, PPE, the other activities we use, not only for COVID, but when we have a hurricane event, we have to go and do follow-up. We have other kinds of medication, other kinds of immunizations, ventilators. And I offer again to take you on a tour after session, because it really is quite stunning. But this was fully federally funded. Our federal funds have been rescinded for this, or in the process of being rescinded. And so this will fully state fund this asset, which actually serves multiple agencies, not just us, but also GMA and sometimes the National Guard. We have naloxone in there, Narcan, which we recently had to deploy to Secretary of State offices around the whole state, as you may recall. That was done out of our RSS warehouse. The prescription drug monitoring program is something very familiar to many of you on the panel. Many of us are registered. What this does, this addition, allows us to continue this very important program, which is both state mandated, but it was state and federally funded. Again, the federal funds have partially disappeared. This will allow us to fully enhance that software, which all of us have to use, using the PNDP, which with 92,000 providers and almost 2 million Georgians getting these scripts, it's an important way to monitor the prescription outlay. And last but not least, the epidemiologists for the low THC program. I've had some off-committee discussions with some of you about this program and how it operates. It's one of our collaborations with the Composite Board, one of many of our collaborations with the Composite Board. But when the program was set up in the mid-2000s, it was not, or 2015, they did not factor in the need for an ongoing data analysis. I think it became particularly important as the dispensaries were set up, and then these large number of additional patients were identified. But we quickly looked at the numbers and said, this can't be right because nobody's ever dropped off. We need to analyze this in the same way we do any other health condition, whether it be an infectious disease or a chronic health condition. And so I had our EPI team work on this. They were able to quickly clean up the data, and we were able to get very accurate statistics. So I'll be happy to share with you. We update these and get that report out every Wednesday to key people around the state who need it, like the Cannabis Commission or the media who request it frequently. But this will provide a permanent epidemiology position to be able to monitor these in an ongoing way. And the last, but not least, is the utilization of our state bonds to be able to ensure that we have some up-to-date equipment in some of our state office building, both the lab down in Waycross as well as the Waycross district office and the Albany district offices, which were, these are old offices. This equipment is over 16 years old. There are things like generators in rural areas, as many of you know, are critical for the to maintain vaccinations and other things that may be in these health departments. And we knew from our own public health laboratory in Claremont a year ago when things froze, we lost everything. We lost many, many specimens. And so having that redundancy and fixing things before they break is clearly the name of the game, and now we have the opportunity to do that. And so we're looking forward, and again, are very grateful to the governor for including this in our budget.
Thank you. You've done a very thorough job. I don't see any questions. We appreciate all that you do in your department.
No,
thank you.
Thank you all so much for letting me talk before dinner. So thank you.
Oh, I'm sorry. I didn't. Let's see. Okay.
Just, Commissioner, before
You
you
did-
go,
Representative Bennett, you did have a question?
thank you, Madam Chair. I have one quick question. I know everybody's wanting to go. When we talked about the pilot program to provide the home visiting for at-risk and underserved rural communities, currently, did you say you have, how many counties are you serving now, and how many counties do you plan to expand to?
Right, we have 21. This expansion will allow 10 more.
Okay, thank you.
And obviously, we have 159 counties, and we have many more opportunities.
Thank you.
And we hope to address them in the future.
That's it.
So
Thank
thank you.
Thank you. Now, we do have, thank you so much. We appreciate it. We do have a number of folks that have signed up to speak. The hour is late. We're going to ask to be brief. That means keep it to a couple minutes. Our first will be Skin Edge.
Thank you, Madam Chair, and members of the committee. I'll be very brief. I'm here on behalf of a company called Pediatrics. This is a national company that is in 38 states, including the state of Georgia. They are composed of maternal fetal medicine physicians and neonatologists. They have offices, of course, in the Atlanta metro area, but also in Savannah, Macon, and they're also looking at expanding into the Columbus and Albany areas. They employ over 5,000 doctors nationwide. These are the physicians that take care of the sickest of the sickest babies. They also treat women with pregnancy complications. They are called in when there are complications with the mother or the children, and they perform great work. They also have a emergency response team that they deploy across southeast Georgia in 24 counties in case some hospitals down there run into problems. We're simply asking that the committee consider a bump of their Medicaid rates. It's been several years since they have been, and we feel like these specialists, we need to encourage them around the state of Georgia. They help save lives, and they do great work, and we would appreciate your consideration of that.
Thank you very
Thank
much.
you.
Let's see, Representative Mathis, I believe.
Thank you, Chairman Taylor. Committee, I'll be brief. I know it's late. I'm here to request a modest amount of funding to support implementation of SB 35. Some of us on the House may remember SB 35 relates to continuous glucose monitors, or CGMs, in our Medicaid population. It received final passage just a few weeks ago, January the 22nd, and it's identical to HB 143 that we passed last year. And the bill passed in the House and Senate overwhelmingly, and it's now headed to the governor's office. Well, first, it would update the coverage criteria of Georgia's Medicaid patients to reflect the CGMs have become a standard of care for diabetes management. Second, it would require the Department of Community Health to use the most cost-effective delivery channel, which could reduce the cost of CGM to the state by as much as 50%. In the states that have passed a similar legislation, they've seen improved health outcomes as a significant cost saving, as CGMs enable better management of diabetes, leading to fewer emergency room visits and other associated costs. I'm going to add a personal note here. I have a son that's been a juvenile diabetic since he was 11. He has one of these monitors. It is fabulous what it has done for him, that he can monitor this when his blood sugar gets low, even in the night. His phone will alert him. It lets him know. It gives his wife peace of mind. He's been able to manage his diabetes. So on a personal note, I know that part. And I see that happening with people that have children of diabetes, elderly parents that may be under the care of family members. This will really open it up for them. So when we say a modest amount, we're asking after SB 35 passed a few weeks ago, DCH asked that we seek appropriations to implement and calculate the amount of money needed is $5.2 million in state's funds. So what I'm requesting, at least 2.6 to be placed in the House version of fiscal year 2025 budget, with the expectation that a similar amount of funding could be secured for the Senate. So I appreciate your thoughtful consideration on this. I do believe, based on some of the points that I made, that I do believe that in the long run that we'll end up saving money due to the calls, the ambulance calls, emergency room, hospital stays, broken bones, lacerations, different things of that, and just a better health condition for these folks, because they will be able to monitor them a lot easier. So I thank you so much for that consideration, and I believe this is just going to help the lives of better have a better handle on their diabetic situation. So it's going to make it better for Georgia. And we do have a lot of people that live in rural areas where it's a lot more dangerous, and we can help folks from even, as glucose, when you have that, glucose glycemia, you can result in death. So we're trying to make sure that we do the things that we can do to help the general public with this. I know this was kind of a stunning thing to ask for this late, but
Well,
if you could
thank
help.
you for sharing that with us. We do understand how important it is. We
Well, thank
appreciate
you.
that.
Thank you.
Thank you very much. Yes, ma'am.
Due to the time of the committee hearing being variable, I was at a Senate meeting and didn't get to sign up, but I saw you earlier today and you invited me to come in.
You could come and speak. You haven't signed up. I've got a number of people that have signed up.
Thank you. I'll wait till.
Okay, thank you. The next one is Melody Trimble.
I was going to say good afternoon, but now good evening, Madam Chair and the members of the subcommittee. I am Melody Trimble, and I have the privilege of being the CEO of St. Francis Emory Healthcare. And I'd like to use my allotted time to speak with you about the needed graduate medical education funding in the 2025 budget. Specifically, I'm referring to Section 17, line 17.12.1 of the House tracking document. As you know, I was here a couple years ago and had the fortune to have you help us fund starting a graduate medical education program at St. Francis. And you were gracious enough to help us obtain monies to open our learning center, which will open in the spring this year. And we're very thankful for that assistance. Just a reminder, we have an internal medicine program that fully, when it's all the program is full, it'll be 10, 10, and 10. We will graduate our first class of 5 in June of this year, so we're very excited about that. In addition to that, to help address the workforce shortage needs in medicine, we also opened a psychiatric residency program. We are now will in July start our second year of that 4-year program, of which they'll have 7. So we'll be the largest community-based psychiatric residency program in the state, and very proud of that, especially since we have the Bradley Center. What I'm speaking to today is that I've been told that we needed 9 slots for our psychiatric residency program and only received funding for 2 of them. I haven't seen the list, but that's what I've been told, in addition to 5 additional slots for internal medicine. So I'm here requesting that the estimated about $51,000 to fund those 2 additional slots so that it will be a 7 program as we intended, that we can get that funding for that. The last thing I'll share with you is you also asked us, could we do more? And I am very excited to say, yes, we can. So I will be back for the 2025 fiscal year, a year from now, as we're going to expand our internal medicine program. Instead of 10, 10, and 10, we're going to make it 15, 15, and 15 to help meet the growing needs of access to our communities in Georgia and surrounding areas. That's my ask, and I appreciate your time.
Thank you. I don't see any questions, and we very much appreciate what St. Francis and the Emory Healthcare System do. Thank you.
Thank you.
Next will be Kelly Ball and Aileen DeGracias.
Madam Chair, members of the committee, thank you so much for giving us the opportunity to speak today. My name is Kelly Ball, and I'm a speech-language pathologist with the Georgia Speech-Language Hearing Association. This is Eileen DeGracias, and she's an occupational therapist with the Georgia Occupational Therapy Association. And we are here today as part of the Georgia Therapy Tri-Alliance. We represent physical therapists, occupational therapists, speech-language pathologists, and audiologists working in the Children's Intervention Services Medicaid program, as well as the Department of Public Health's Babies Can't Wait program. So who are we? We're the therapists who are helping kids when they leave the NICU learn to eat by mouth so they can stop using a feeding tube. We're the therapists who are helping kids with delays learn to walk, learn to talk, learn to dress themselves, learn to feed themselves. Early intervention is really critical. Addressing these needs early leads to better outcomes for the kids in general and reduces the needs for more intensive and costly intervention later on. Unfortunately, the problem we have is there's a lack of therapists, especially pediatric therapists, which results in an access to care issue where the children who need these services are unable to get them. Babies Can't Wait requires that therapists work in the homes, work with the family in their homes during their daily routines to best help the children. Unfortunately, there is no reimbursement for the time or the expense of travel. It's kind of heartbreaking as a therapist to hear someone say, I don't know why they call this program Babies Can't Wait, because all we do is wait for services. So we're here today to try to help fix that problem. We have 2 requests. One is for funding for a rate increase for providers working in these programs. And then in addition, DCH has a home visit rate for other providers, and we're asking for a similar rate structure for therapists. And Eileen is going to talk a little bit about the workforce issues.
Good afternoon, good evening. My name is Eileen DeoGracias. I'm a pediatric occupational therapist, and I also own my own clinic. So part of the packet that I shared with you today is a printout from the Georgia Department of Labor, and it says there that physical therapists, occupational therapists, and speech therapists are part of the hot jobs for Georgia for doctorals and master's programs. And there is a huge need for therapists in Georgia and across the nation. This results in therapists demanding higher salaries and better benefits. However, higher salaries without corresponding increases in reimbursement rates create hiring challenges and affects the sustainability of small clinics like ours. Qualified pediatric therapy providers are becoming increasingly scarce, which directly hampers our ability to deliver essential services to children in need, just like what Kelly said. Current medical reimbursement rates for pediatric therapy are insufficient, preventing us from competing with hospitals, schools, and adult therapy practices reimbursed at much higher rates. We are also losing therapists every day to these settings because of the pay rates. CIS speech therapy reimbursement rates have not seen any increase since 2007, while OT and PT reimbursement rates have remained unchanged since 2017. Such prolonged stagnation threatens the sustainability of our practices and jeopardizes our ability to continue providing vital services to children who rely on us. So the reason why we're here is we are imploring you to consider the urgent need for increased Medicaid reimbursement rates for CIS and Babies Can't Wait providers. We are also asking you to allocate funding in the budget for travel reimbursement for CIS therapy providers. Lastly, we are asking the committee to allocate funding in the budget for utilization of OTAs and PTAs in the CIS program. My colleague, Dr. Amy Schaefer, will talk about that shortly. We believe that by doing this, we can address the workforce shortage, alleviate salary disparities, and ensure the sustainability of pediatric practices. Thank you so much.
Thank you, ladies, for sharing that with us. We appreciate it. Next is Amy Schaefer. I'm going to ask if we can keep it as brief as possible. We know there's a lot of needs. Thank you.
I did want to say real quick, Representative Taylor, that the numbers on the back are new numbers we did receive from the Department of Community Health recently.
Thank you.
Hello. My name is Dr. Amy Schaefer. I am an occupational therapy assistant, and I'm also the program director for one of the occupational therapy assistant programs here in Georgia. And I come to you today after these ladies to also speak about the our request. And first, thank you for hearing us our request today. But we are coming to request again for the services of assistance to be implemented with the Medicaid plans that we have here in Georgia for reimbursement purposes. We did get support from this committee last year for that. However, you may remember that the governor disregarded those items in the 2024 budget. So we wanted to remind you that the issue with the children of Georgia not receiving services is still present. That hasn't gone away. And the use of occupational therapy and physical therapist assistance is one way to fill that labor shortage that these ladies just discussed, because there's a ready workforce that is licensed and state regulated to step in and help fill that shortage, and also to bring the children of Georgia services and reduce those wait times, especially in our more rural areas. We handed you guys a fact sheet, so if you'll look on the front, there's some information about the facts about Medicaid in Georgia, and you'll see that Georgia is an island by itself with our surrounding states all recognizing assistance to practice with Medicaid. And then on the back is a listing of the local OTA and PTA programs for the state, and current research shows that most community college graduates tend to stay in their areas and support the workforce there, so we wanted you to have a visual of where those workforce people might be coming from. Thank you.
Thank you. I don't see any questions. Thank you very much for your sharing this information. Rick Ward.
Thank you, Madam Chair, members of the committee. I'm Rick Ward. I'm with the Georgia chapter of the American Academy of Pediatrics, but I'm here today speaking on behalf of the Patient-Centered Physicians Coalition of Georgia. Our coalition is over 20 years old now and represents the 4 medical specialties of pediatrics, internal medicine, family medicine, and OBGYN, as long as the Georgia Osteopathic Medical Association. That comprises nearly 10,000 physicians in the state of Georgia. And I guess like the prior speaker, I'm back here because we spoke to you a year ago. In fact, I looked at my letter. It was a year ago yesterday, so you're right on pace, and asked for increases for 2 primary care sick visit codes and 4 OB codes, which you approved and were included in a 24 budget of about $18.6 million. And so those also were a feature in the governor's disregard, so we're back. The need is still there, and we would appreciate your consideration. That was then, this is now, so we are working with the House Budget Office and the department to sharpen as best we can our projection about what the cost would be, given the fact of changing the FMAP and the reduction in enrollment that Medicaid has somewhat experienced as the pandemic has wound down and redetermination kicked in. Thank you, Madam.
Thank you very much for sharing, and we do understand the needs. Thank you very much. Julie Emmons?
Hello, Madam Chair and members of the committee. I'm Julie Emmons with Human Coalition. I was walking around the Capitol earlier today and saw Representative Petrie, and he said, Julie, you should come talk to our committee. So here we are. Thank you for the suggestion, sir. I'll be very brief. Human Coalition is a pro-woman, life-affirming organization with a unique and innovative approach to reaching women online who are facing unexpected pregnancy and bringing them into a comprehensive system of care. We care for pregnant women in 19 states. We serve about 545 a day and served 40,000 pregnant moms last year. Approximately 2.2 million women in the state of Georgia are between the ages of 15 and 44. And approximately 5% of all women of childbearing age will face unexpected pregnancy in the next year. Our long-term care program goes beyond traditional pregnancy-focused assistance to top concerns for clients, including housing, employment, education, and access to affordable health care. We operate a privately funded telecare clinic here in Georgia, and we would love to expand those services in partnership with the state. I have materials for you that outline 2 funding options. One is for a telecare clinic, and the other is for an innovative maternal health disparities program that we operate for high-risk moms. Finally, when you help a pregnant mom, you're helping 2 precious lives and making a difference for an entire family for generations. Our team is poised to expand this innovative program right here in the state of Georgia. Please let me know if you have any questions, and thank you very much for your consideration.
You do have a question? Okay.
Hello, ma'am.
Hi, how are you? So
Good.
you take care of the pregnancy. How long is your aftercare after the baby is born?
It's average of 3 years, but it can go longer than that if she needs us longer than that. We serve with licensed social workers and licensed nurses.
Okay, thank you.
Mm-hmm.
You have no other questions. Thank you
Okay.
for sharing with us. Next would be Gaylord Lopez.
Madam Chair, good evening, and committee members. Thank you for allowing me to speak. My name is Gaylord Lopez. For the last 36 years, I've been Executive Director of the Georgia Poison Center. Just a little bit about us. We're funded at a current rate of $1.37 million, and we're asking for an additional $359,000 to our budget. As you remember, the Georgia Poison Center or may not know that Georgia Poison Center has been around serving Georgians for over 50 years, providing an emergency hotline for poison emergencies. We provide service to the 159 counties here in Georgia, taking calls from healthcare professionals as well as the general public. Those calls total of about, on average, 100,000 calls a year, which ranks us as the second busiest poison center in the United States. At its core, our job is to deliver free advice in a timely manner in order to properly manage a poisoning event. Now, whether that's at home or in the hospital, we're there to make those decisions. Who are the folks that make those decisions? It's not AT&T operator number 12 and 13 that you're calling. You're talking to healthcare professionals that are physicians, nurses, and pharmacists. And what kind of questions are there what kind of questions are being asked of us? People exposed to household chemicals, pesticides, over-the-counter medicines, prescription drugs, bites and stings. Someone asked me, Dr. Lopez, how many snake bite calls do you get a year? Over 500 snake bite calls annually to our center. Managing these cases, making sure that proper therapy is recommended. I just did a story last week on the dangers of water beads and when people intentionally or accidentally ingest these. So the Poison Center answers these type of questions, and it's through our tracking and monitoring that we're able to stay proactive regarding these threats and these trends. I might want to remind you that we were at the heart of answering a number of questions from consumers during the ConAgra peanut butter scare of '07. We were there answering 1,000 calls within a couple days to alleviate the fears of possible salmonella. What about in 14 when we had the anthrax scare? The FBI thought they could handle the call volume. They said, Dr. Lopez, we don't need you. We're going to post our own phone number. Well, their calls, the calls that came into their center overwhelmed the telephone system, and they came running back to us and said, with your capacity, can you answer these calls from the public regarding anthrax? Just in 2017, 2 major events happened. You probably remember the trend of laundry pods. Whether they were intentionally or accidentally ingested, the Poison Center was there to talk about the hazards of eating the laundry pods. And probably the hallmark event that happened in 17 that we were responsible in identifying was the number of people getting sick and dying in central Georgia as a result of counterfeit Percocet. You probably remember that event. So thank goodness, though, poisonings are not killing people on a daily basis. In fact, 85% of the calls that we receive require no therapy. Just think about the cost savings there of not going to an emergency room and spending all kinds of money. In fact, it's projected that over $127 million are saved annually, of which $20 million is directed at the state's share of Medicaid. So we are saving the state millions of dollars each year. While responding to human poisonings is our bread and butter, we've been able to partner with DPH to do a number of other non-traditional projects. Think about this: in the early 1990s, the Poison Center was asked to help with disaster preparedness for the 1996 Olympics. In 2005, when Hurricane Katrina hit, the Poison Center was asked to develop a call center to help displaced victims find childcare, healthcare, shelter, food. That was the Poison Center, but we were answering these calls under the bigger umbrella of the Department of Public Health. Then in '09, we got hit with H1N1. The DPH asked us again to develop another call center to respond to these caller questions. And then recently, COVID hit. We ran the COVID hotline for the state and answered questions about COVID, about signs and symptoms, about vaccine safety. That was all the Poison Center. So the work goes beyond just traditional Poison Center work. The money that we're asking for is going to keep us as that emergency resource. It's going to allow us to continue to decrease morbidity and mortality in our state and save healthcare dollars by preventing unnecessary visits to the ER or to the doctor's office. And for us, we need to stay proactive so that we can combat these new challenges and maintain a high level of preparedness in order for us to protect public health. Thanks, and I'm...
Thank you very much for sharing that. We do realize that I come from a snakebite area, so thank you very much.
You're welcome, Madam.
Thank you. The next on our list is the Alzheimer's Association, Nancy Petra.
Good evening. My name is Nancy Petra. I'm the Director of Government Affairs for the Alzheimer's Association Georgia chapter. And we'll be super brief. I had a larger presentation that I'll be happy to send to Morgan, and you guys can look through more of the data and the statistics. But I did leave on your desk our infographic, which gives you a little bit of the national statistics and data, and then Georgia-specific stats on the prevalence of Alzheimer's. One of the things that we're focusing on this year is ways that we can reduce risk and get to early detection faster. So 7 years ago, you were kind enough to put $350,000 one time in the Department of Public Health budget to do a brain health awareness campaign around the Medicare annual wellness visit for people over the age of 65 to get their cognitive exams. It was called the Think About It campaign. It was a very successful campaign. Research shows us that if we can get people talking to their doctors earlier about their cognitive issues when they have mild cognitive impairment, it's not normal aging, the earlier we can start to lower their risk by having them work on the modifiable risk factors, lifestyle changes, managing other chronic illnesses that they may have, but we need to get them in talking to their doctor. So we're looking to ask for one-time funding again in the 25 budget to run a brain health awareness campaign to promote going in and talking to your doctor about cognitive impairment early. People in their 40s and 60s, people are developing younger onset in their 40s and 50s, and so we want to get them talking to their doctor, getting those cognitive exams earlier, and I've left you a fact sheet on how we want to do that promotion through the Department of Public Health. Be happy to take any questions.
You have no questions, and thank you. We
Thank you.
appreciate that. Lauren Paulo.
Thank you so much to the committee. Kathleen Tehan had jury duty, so I'm here in her stead with the AIDS Coalition. They are advocating for a $1.4 million line item in the DPH budget to continue some of the great work that this body has done over the last few years on routine care and testing. This is specifically related to hepatitis C, identification, tracking, linkage to care. DPH needs a little bit of supplemental funding to really put into place what you guys have already started working on in the past through syphilis tracking and screening, especially for that postpartum population. So 19% of, or excuse me, the state of Georgia has a 19% increase in HCV infections, many of which are in women in childbearing age. So we are just really hoping that we can shore up a little bit of funding to get that ask where it needs to be. So thank you very much.
Thank you very much. I appreciate that. Next is Jim Mellencon.
Hi, I'm Jim Melançon. It's a very French name, but you got the rest of American pronunciation, and I probably should be with my family back in Louisiana today, but this was more important for me to be here. I'm the Senior Vice President of Government Affairs for Aveanna Healthcare. Aveanna Healthcare is a national provider of healthcare, but we are based here in the state of Georgia. Our headquarters are here in the state of Georgia, and today I'm here to talk to you about the GAP program and the need for a rate increase for our nursing rates for GAP. You heard a lot here today about pediatrics and what we do, and we take care of many of the 1,700 children who are enrolled in the GAP program. We provide private duty nursing. You have a folder there. I think that I won't belabor, but you have a one-pager here detailing our ask, as well as a comprehensive letter that spells out for you the ask. The ask would be, you heard Commissioner Carlson earlier today talk about the waiver studies that have been commissioned that are being funded. One of the things that study, while much needed, would, for private duty nursing rates that are provided in those programs, in the COMP, now ICWP, and the Elderly Comp Waiver Program. I think we all need that chart a lot that he put up there to remind us of the waiver programs. It would create a substantial disparity in the rates between what the current gap rates are and what the rates would be in that program. And what that would mean is that we would see a shift in nursing care. We know that would be where that care would go to. Remember, these gap patients who are in this program are the children with medical complex conditions. Many of them are on ventilators, trachs. They are G-tube patients. They require continuous nursing care. Otherwise, they would be in institutions. We've seen a study that we've commissioned using Georgia Medicaid data shows the comprehensive cost of PDN per day in the home roughly about $500 compared to, at a minimum, $5,000 if these patients remain in a hospital. So this is a very cost-effective service that we can provide. However, you also heard the therapist. We are competing now. We will be competing with programs within Medicaid because there would be this substantial rate disparity that we'd see. So we're asking, as you can see in the ask, we've estimated that the ask would be about $16 million to make those rates come up for the GAP program, equivalent to at least the rates that are being recommended and funded in the governor's budget for the ICWP waiver. So I know it's been a long day. I'm not going to belabor, happy to answer. My colleagues are here as well, and I know several other providers who provide this much needed service to many patients. We have 8 locations throughout the state of Georgia servicing roughly 250 patients and families.
Thank you. We do appreciate what you do in the service and that you provide to our citizens. You do have a question. Chairman Petrie?
Yes, thank you, Madam Chair. I'll be very brief, sir. Just want to emphasize something for my colleagues' benefit. My understanding is Beata, which is another large provider of GAP services, left the state because of the low rates. Obviously, that's important that we recognize. And also, I wanted to emphasize, my understanding is last year we did have an increase in there, and that was also redirected by the governor in last year's budget. So,
yes, and not only Beata left, but other providers have reduced come into the market. We have taken on those families at those rates, and we're very appreciative. We did not get an increase last year, and now this rate would help us retain nurses, sustain the program, save the state overall dollars. These patients are staying home with their families and in their communities.
Thank you.
Thank you very much.
Thank you very much. We appreciate it.
Appreciate it. Thank you.
Next would be Cindy Shepard. Cindy Shepard, are you here? Okay. Heather Bishop, please come up to the podium.
Good evening, Madam Chair and members of the committee. I want to amen the sermon of our counterparts at Aviana. We at Advanced Care Partners are also in the pediatric program to provide care for patients in their homes. There are about 1,800 children across the state of Georgia. There is not one county in the state of Georgia that does not have a medically fragile child within its borders. Without the additional funding for the GAP program, we will see the end of the pediatric program as we know it. We will not be able to retain our caregivers, and these children who desperately need in-home health care will suffer. And so we are asking, as the gentleman before me said, for a $16 million funding from the state in order to keep parity within the programs with NOW and COMP and making it possible for us to continue to provide these valuable services. So we thank you so much for your attention and appreciate the time and the consideration for the request.
Thank you for what you do and the services you provide to our most fragile. Thank you. Next would be Andy Lord.
Thank you, Madam. Thank you, Madam Chair, members of the committee. My name is Andy Lord. I'm here on behalf of the Sickle Cell Foundation of Georgia. First, want to thank this committee again for the support that you've already rendered to the Sickle Cell Foundation, and also to our colleagues at DPH who have been great partners in implementing that. As you all know from our previous presentations in years past, the Sickle Cell Foundation has adopted a two-prong approach to addressing sickle cell in Georgia. One is a urban focus, population centers where we have a higher incidence, and the other approach is a rural focus where we have a mobile health clinic, a mobile health hub unit that was parked out last week in between. I hope y'all had a chance to come by and visit our mobile health unit that we take around the state. Our brick and mortar sites are currently located in Savannah, Augusta, Columbus, and Atlanta. Our mobile unit we designate to only go to areas that are greater than 100 miles from hematology care. So we have a very specific rural and urban focus. Additionally, with the funding you all have already provided, we do provider trainings and mid-level trainings around the state. There's still a lot of misinformation about sickle cell. We fund CBOs, CHWs, et cetera. For this year's budget request, I wanted to, update that we do have a higher budget request this year than we traditionally do, but really wanted to stipulate that this is because when the WellStar hospitals closed, we had a significant surge or significant increase in gaps in care for sickle cell. And we have tried to respond to that by establishing a center and clinic here in Atlanta at our administrative headquarters, where a lot of patients were just beating a path to our door because they had lost their care via WellStar. So our budget request this year is for $3 million, but I would like to stipulate that $2 million of that is for the Atlanta Wellness Center to handle this significant uptick in patient population we've seen in the aftermath of the WellStar closing. We expect that wellness center to see between 900 and 1,000 patients per year. And again, this is direct service delivery. Also, as part of our budget request, we're asking for additional funding for an additional mobile unit to go to more of these rural areas. What we're really we have seen our method of urban and rural be very effective. We're simply trying to scale that up to reach more. That's the gist of what we're after between the new wellness center, the mobile unit, and the further funding of the CBOs and the satellite centers. We do also fund CBOs in Covington, Hinesville, and Hampton. Some of the peripheral impact that we have, obviously reduction in hospitalizations, but this is also a very painful disease, and we work with our patients also to help them with the opioid epidemic that we see so often that accompanies chronic disease. So with that, Madam Chair, for the sake of time, I will stop there.
Okay, thank you. I don't see any questions. I appreciate your, we have Calvin Smyrie. If you'd like to come up to the podium.
No, I came to observe. And I would like to just say hello to you after that.
All right, thank you. Good to see you. We have Gabriel Carter.
Thank you, Madam Chair and fellow committee members. Gabriel Carter with ACCG. We represent all 159 counties. I'll be as brief as possible before you this evening. I know that I don't have to explain to this committee how important EMS is to counties, the counties you all represent, and communities all across Georgia. So we're requesting that this committee consider increasing the EMS Medicaid reimbursement rate to the rural and urban Medicare rate. This is going to be about a $6 million price tag, but we believe that this is the first step to strengthening our EMS in our communities and really helping with some of the problems that we're facing, such as wait times, lack of personnel, and things of that matter. So I know that you all know the importance of EMS to our communities. Just one thing I just wanted to say before I take my seat is in the one-pager, you'll see a list of examples of different counties and how much those counties are actually contributing towards providing EMS for their residents. There's some counties that are having to pull several hundreds of thousands of dollars out of their general fund to help just provide EMS. This is not a service that pays for itself. Oftentimes, counties are having to supplement it out of their general fund, so we're just asking for your consideration to help provide some funding. So thank you, Madam Chair, for the opportunity.
Thank you. That is our list of speakers. Now, I know we have some that wanted to speak, so if you would come up to the podium, introduce yourself and what you're representing. And we do ask anybody else that speaks to be brief.
My name is Julie Allen. Thank you so much for allowing me to speak and your invitation today when I saw you and explained my concern. I'm here to say that you all are heroes of the 2024 legislative session. Thank you for passing HB 576 in the House. That happened yesterday, and I'm so grateful. Time will show the stand you took was a step for informed consent and bodily autonomy. The right to refuse experimental medical treatments is a basic human right. No one, including those who are medically fragile and in need of a transplant, should be mandated to take an experimental medical treatment via emergency use authorization. I'm here to share with you a troubling social media post I saw yesterday posted by the Georgia Department of Public Health. That's what I've handed out to you. If you'll look at the post, it says double up on protection for you and your loved ones by getting both your flu shot and COVID vaccine at the same time. Visit dphga.gov to book your appointment. Twice the protection, flu vax plus COVID vax. Does data support safety of doubling up? Is the Georgia Department of Public Health a guardian of public health, safety, or is it a tool of big pharma? Senator Bob Hall of Texas sent a letter on February 5th, 2024 to Executive Commissioner of Texas HHSC, Cecily Irwin Young. That's the Texas equivalent of Georgia Department of Public Health Commissioner Dr. Kathleen Toomey. This letter is summarized in this preview. There are insufficient studies conducted by the drug manufacturers regarding the potential risk of DNA integration in reproductive cells, particularly concerning the lipid nanoparticle delivery system. The lack of comprehensive research in this area raises serious questions about the long-term effects and safety of the vaccines, especially with regard to reproductive health. The letter is significant. That's just a preview. I'll be brief, but it says, I'm writing to you to bring to your attention some significant concerns related to the promotion and distribution of the COVID-19 vaccines, particularly those manufactured by Pfizer and Moderna. Recent developments have raised serious questions about the safety and potential risks associated with the Pfizer and Moderna COVID-19 mRNA vaccines. The discovery of host cell DNA fragments within these vaccines has triggered alarm within the scientific community and among the general public. The revelation demands immediate attention and a thorough investigation into the possible implications for public health.
We appreciate your sharing this information with us, but this is really a budget meeting, and we need to, my impression was that you had something relating to the budget to talk about. So.
Well, the need is for data transparency to find out why.
Right.
And so there is a bill in New Hampshire relative to data transparency, and there are cost-saving measures relative to that. But yes, the issue is significant, and that the Georgia Department of Public Health, at which Kathleen Toomey spoke at this hearing, there is great concern that this is being promoted when others are calling, as Surgeon General Joe Latipo is.
Well, we do appreciate the information, but again, we're looking for line item budgets today. Thank you. I appreciate it. Were there any others that wanted to speak today? Well, I appreciate y'all being here and hanging in with us, and we are adjourned.